Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. It's estimated that 1 in every 100 people in the U.S. have been diagnosed with celiac disease, a chronic immune disorder caused by an intolerance to ingesting a protein called gluten. Gluten is found in grains like wheat, rye, and barley, but it may also be found in medications and cosmetics. The consequences are chronic and so varied that diagnosing celiac disease is often missed or delayed. Some experts estimate as many as 2.4 million Americans could be suffering the symptoms of celiac disease and not even be aware of it. That's why I'm talking with gastroenterologist Dr. Jose Parungao for this episode of MedStar Health DocTalk. I'm your host, Deborah Schindler. Thanks for being here to help us understand this disease, Dr. Parungao.
Thanks for having us, Deborah. Definitely a pleasure to be here.
Celiac is described as an immune disorder, which means that when a person with celiac disease ingests gluten, their immune response mounts a sort of defense against it. What actually is happening?
Right. So for celiac disease, as you've alluded to, once an individual with actual celiac disease is exposed to gluten in the diet, part of the immune system recognizes gluten or gliadin as foreign, and it triggers an immune response typically mediated by a specific segment of the immune system called T cells. Once that immune response is triggered, and this typically occurs in the lining of the small bowel, an inflammatory response to that exposure over time leads to villus atrophy. So what I mean by that is in the bowel, in the very microscopic level, you see finger-like projections called villi, and these villi are responsible for absorption of nutrients in our diet. So over time, when that sort of atrophy, or when those finger-like projections start eroding or flattening out, the absorptive capacity of the small bowel is greatly diminished, leading to gross malabsorption over time.
Which could have, I guess, a lot of different consequences on one's health, obviously, if they're not absorbing vitamins and things.
Absolutely. And that's typically one of the presenting symptoms. So we, in our practice, see a lot of patients referred by the primary care physicians for issues such as iron deficiency. The prevailing thought is they're worried about bleeding, but in celiac disease, it's actually not bleeding, but an inability or an inefficiency in absorbing iron, which is the pathology. So that's one, but other manifestations, for example, if you're not absorbing vitamin D properly, is that can lead to bone loss, osteoporosis, and things of that nature.
But a lack of absorption would take a while, really, for those
Correct.
symptoms to reveal themselves. What about some other symptoms of celiac disease that might be more immediately experienced by a person?
Yes, actually, that's a good point. So typically when malabsorption occurs, that exposure to gluten has occurred over time. But some earlier presentations can be things such as diarrhea, and believe it or not, bloating. Over the course of the years, I've diagnosed quite a few patients on the basis of bloating alone, and they turn out to have celiac disease on further testing.
So I'm also seeing some other symptoms that might be fatigue, skin rashes.
Yeah, so the skin rashes associated with celiac disease is a separate disease entity called dermatitis herpetiformis. So as the name implies, the rash resembles herpes, but on the pathology, when they do skin biopsies, it's more consistent or more diagnostic actually of celiac disease. But it's important to note that not all patients with celiac disease develop this condition, but yes, that's a manifestation of celiac disease, which is specific to that condition. other manifestations that have been described, and I've seen some of it, although the pathophysiology is unclear, is that some patients do develop neuropsychiatric symptoms, such as mood disorders. Some of it, at least neurologically, potentially could be explained by the malabsorption of B vitamins, for example. So certain neuropathies can be seen in patients with celiac disease. But the psychiatric standpoint, as I've mentioned, they've been described in the literature, but it's been poorly understood thus far.
Well, that's quite a stretch from mood disorders to fatigue and diarrhea. I mean, who's putting their finger on celiac disease? I would think that with those symptoms, because those could be so many different things, right? Is it hard to diagnose?
Yes, actually, that's a good point. And that probably is why celiac disease isn't tested for as often as it should be, in my opinion. So celiac disease actually has been described in terms of its presentations as either the classic type of celiac disease, which is what we talked about in terms of diarrhea, iron deficiency, anemia. But there's also an atypical presentation, those who present with very minor GI symptoms, for example, bloating, as I just described earlier, but happen to have very subtle clues in their history, such as the anemia or osteoporosis. There are also patients with celiac disease who present subclinically, meaning they have no symptoms whatsoever, and celiac disease is diagnosed incidentally. So, for example, I'll give just one example. Let's say I'm doing procedures like I was today for other reasons, and on biopsies, they're found to have findings highly suggestive of celiac disease, and they have no symptoms, but as I mentioned, they can present in that fashion. There's also a presentation called latent. So essentially, those are patients who've been diagnosed with celiac disease in childhood, respond to treatment, and then when they enter adulthood, they essentially enter remission or a silent phase of the disease. And
is it possible that they've grown out of it?
Yeah, so that's the thinking when it comes to latent celiac disease, is that they're treated with a gluten-free diet, symptoms resolve entirely. And even with the reintroduction of gluten, interestingly, some of these patients actually continue to do well. So yes, there are cases that have been described that are consistent with that, but in my experience, I actually haven't come across that as of yet.
The difficulties in diagnosing that you just described, it makes sense then that the long-term implications of celiac disease are the greater risk. And I'm going to go down a list of these and get you to comment. Some of those are, you mentioned the osteoporosis, gallbladder malfunction, heart disease, infertility and miscarriage. These are all very serious. Iron deficiency and anemia, you mentioned that one. Lactose intolerance, which is how it really is probably first understood by someone, right, that they are lactose intolerant.
Right.
Liver failure, neurological symptoms, including attention deficit or hyperactivity disorder, headaches, lack of muscle coordination, seizures, dementia, neuropathy, myopathy, multifocal... I'm not even going to...
Leukoencephalopathy,
Thank
yes.
you. Thank you. Pancreatic insufficiency, small intestine cancer, non-Hodgkin's lymphoma.
Correct.
Those are some really serious health concerns if celiac disease is left untreated.
Absolutely. So a lot of these conditions can persist and impact one's health significantly if celiac disease is left untreated. Absolutely. Fortunately, a lot of these are actually reversible with the introduction of the treatment, which is the gluten-free diet. There are a couple here, which you've mentioned, which is small intestinal cancer, non-Hodgkin's lymphoma, which is seen in the 5th presentation of celiac disease, which is refractory celiac disease. So that's where celiac disease, despite the gluten-free diet, persists. The type of lymphoma in this particular situation is called enteropathy-associated T-cell lymphoma, or EATL. So as the name implies, it's a lymphoma that develops over time when refractory celiac disease is untreated. And again, despite the gluten-free diet, these patients unfortunately develop these conditions, and the treatment involves immunosuppression to varying degrees. But
are you still, as a gastroenterologist, involved with the care of someone there, or are they then now moved on to a medical oncologist for those cases?
So, I think once lymphoma develops, yes, then we would need the help of an oncologist in treating that specific condition, but we would still be a part of that patient's multidisciplinary care.
I'm imagining that there are people listening to this and they're thinking, oh my goodness, she just read off a whole list of things that are very concerning.
Sure.
And I have diarrhea all the time, or I have headaches all the time. Could I have celiac disease? When's the right time for someone to go check out their concerns, and what is the diagnostic process?
Right. To answer your first question, I think as soon as any of those red flags come about, definitely consult your primary care doctor and talk about celiac disease. And if the primary care physician may not necessarily be as comfortable with a diagnosis, then by all means, we're happy to see them. Going on to your second question, in terms of diagnosis, the first screening test would be a blood test. The blood test would detect antibodies to gluten. There are several involved, but the screening tests actually come in a sort of a package now where all the antibodies are checked simultaneously. And if it is positive, the gold standard is a biopsy, which we obtain during an upper endoscopy, where we obtain biopsies in the small bowel. And that would be the gold standard of diagnosing celiac disease.
How are you extracting that biopsy?
An upper endoscopy. Right. Yes. So essentially, to describe that procedure, which we do in our practice routinely, is you come into an endoscopy suite, you receive anesthesia. An endoscope, which is a flexible camera, is put down your mouth, into your esophagus, and into the stomach, and into the first part of the small bowel, which is right past the stomach. And that's where we obtain those biopsies.
I assume that's an outpatient procedure. People come in and they go home the same day.
Correct. It's a very similar procedure to a colonoscopy. We just go the other end.
Okay.
Right.
I'm reading now about a breath test to test celiac disease. How does that work?
I'm not aware of a very good breath test for celiac disease. As I mentioned, as of the moment, the standards of care still involve doing the blood test to check for antibodies and then the biopsies. But more recently, in terms of diagnostics, one of the things that's been introduced, because there are certain situations where there are certain diagnostic dilemmas. So, for example, a patient comes in with a positive blood test. We go in, we do the biopsies. The biopsies are non-diagnostic or equivocal. Then what then, right? So there's discordance. There's one thing telling you I have it. There's another thing telling you I may not have it. So one of the things that's been proposed recently in the updates to diagnostic testing is to do genetic testing. So one of the identified target, right, risks, is in terms of genetic predispositions, is something called human leukocyte antigen, or HLA, specifically DQ2 and DQ8. So those are genotypes that are identified using a blood test. So if abnormalities are identified, then that sort of breaks the tie, right? So if in that situation where there's discordance between biopsies and blood and antibodies, a positive HLA test would then clinch the diagnosis or rule it out. So if a patient were negative for both DQ2 and DQ8, the diagnosis of celiac disease is extremely unlikely. The experts hypothesize that majority, or if not all, patients with actual celiac disease are positive for one or both of these genotypes.
Well, since the data puts misdiagnosis at such a high percentage, what is celiac often mistaken for? By
far, I think in my practice at least, it's often punted off as irritable bowel syndrome. So patients with those very non-specific symptoms, bloating, diarrhea. Because to be fair, there is a disease entity with irritable bowel syndrome with diarrhea predominance, for example, which is more of a functional disorder. But clearly, celiac disease has a biologic genetic component to it, and I strongly encourage testing for celiac disease before such a diagnosis is made.
Let's say the genetic test comes back positive for the genome. Does that suggest that other members of the family may also have celiac disease?
That's a great question, and that's actually something I do encourage my patients to advocate for, because there is a strong genetic component to it. And in fact, I have patients who have come to see me because, hey, my sister was diagnosed with celiac disease. I'd like to get tested. And yes, that certainly is something to strongly consider, and I've certainly done that for patients.
What's the average age of the patients coming to see you for this?
Actually, that's also a good question. I wouldn't necessarily because classically celiac disease has been diagnosed, in children, adolescents, but I've diagnosed celiac disease in patients as late as their 60s. So it's that sort of thinking has kind of shifted. And as you've noted earlier, the prevalence of celiac disease currently is estimated to be 1%, but that number may very well be higher because, again, it's not being tested for as much. It's not in the general gestalt as of yet.
I'm curious about that. People coming to you for the first time for celiac disease in their 60s, are they ignoring symptoms? Did they have it all along, or has it just gotten worse because of those long-term implications?
Right. So in that situation, patients may have had symptoms all their life and misdiagnosed by other clinicians, for example, or yes, they've developed something like iron deficiency anemia, for example, and were sent to us to evaluate that, but they end up diagnosing them with celiac disease instead of bleeding, for example. So celiac disease never ceases to amaze me in terms of how patients present, because what I've learned over the years is there's definitely no one-size-fits-all kind of patient when it comes to celiac disease.
Okay, let's talk about the treatment, which is kind of disturbing to me because you've already said that the only treatment is to stop ingesting gluten.
Right. So, and as of now, it is the only approved treatment for celiac disease. If you think about it, right, effects of celiac disease are seen when one is exposed to the offending agent, which is gluten. So I think one way to think about it is, and it's not the same, but it's at least an easy way to understand it. If one is allergic, for example, to nuts, it sounds intuitive to never expose yourself to nuts, right? So with celiac disease, I think the reason it's a little bit more challenging to grasp when it comes to avoiding gluten is that the effects aren't as immediate as it would be for an allergy, right? So for someone with a nut allergy, they get exposed to nuts. More often than not, they need an EpiPen, because if not, something catastrophic may occur. With celiac disease, a patient can ingest gluten today and not feel the effects maybe a few days down the road, or even weeks down the road. It depends on the amount of gluten they're exposed to. But yes, it's the only recognized way of treating celiac disease as of now, because without the exposure of that offending agent, the immune response isn't mounted, allowing your small bowel to go on living its happy life moving forward.
I think after our conversation today, I'll have a greater appreciation for when I see gluten-free on labels of food. What are some of those foods? We talked about the grains, wheat, rye, and barley. Where else might gluten be found that people should be wary of?
So that's a great question. So aside from the normal breads, containing any of these agents, things that we don't think about too much are beer, for example, ale, lager, and even malt vinegar. So all of those things would likely contain gluten. But fortunately, to your point, in terms of gluten-free, they've actually started manufacturing gluten-free beers now. And I tell that to my celiac patients who, it's one thing I tell them all the time is it's not like a death sentence. It's not the end of the world. A lot of manufacturers have really recognized that this is more prevalent than we once thought. And so there's technically a market for that. I'm sure if you've perused groceries recently, there's likely to be a gluten-free section now. That's been a godsend for our celiac patients.
I actually just, your cell phone is always listening or paying attention to what you're looking up. And it sent me a video ad for an app that you can download. Mm-hmm. And you put in that you have celiac disease, and it will list all of the foods that you should not eat. And
right.
It was actually a really impressive guide or tool. Mm-hmm. Do your patients ever use that you have any feedback?
So some of them have reported using apps to help them out in terms of the gluten-free diet. But I think this is a good segue into part of the holistic approach when it comes to the management of celiac disease. The acronym that they like to use in terms of management is, not surprisingly, Celiac. So C is the consultation with the nutritionist. So that's key whenever I diagnose someone with celiac disease, involving a nutritionist who has experience with the gluten-free diet is very important. Education about celiac, that's the E part about the disease. L is the lifelong adherence to the gluten-free diet. There's just no getting out of that. I is identifying deficiencies such as iron deficiency, vitamin D deficiency, the B vitamins. A is access to support groups or advocacies for celiac disease. And C is the continued follow-up with a gastroenterologist and the rest of the team members to manage the disease effectively.
What other products do people need to be wary of? I mentioned before cosmetics and shampoos, but what else?
So apparently there are some medications that are, when they're manufactured, may contain gluten. So that's one area to be mindful of. So definitely reading the labels are key. The other thing is oats. Oats seem to be a topic that needs to be monitored very closely. The current guidance is that patients with celiac disease can consume oats, but there's always the thought of how the oats were processed, for example. So if oats were to be introduced, it should be under the close guidance or monitoring of both the nutritionist and the gastroenterologist.
The most recent advancements in treating celiac disease include enzyme therapies, showing some promising developments in treatments that could help break down gluten in the digestive system, potentially reducing symptoms for those who accidentally ingest gluten. What can you tell us about that? So
there are treatments that are still in development, so they're not yet approved. There are promising aspects of the therapies. There are also some other therapies that include genetically modified wheat products that don't contain gluten, for example. But again, all of these are still in development, so I can't actually recommend any of them at this point. It still goes back to the gluten-free diet as of now.
Fair enough. What about vaccines?
Yeah, so I think I've read about some of these, but again, I think it's too early on to really look into that. But if the clinical trials are successful, then that would be obviously game-changing. But I'm just wondering who to administer these vaccines to. It may be targeted in terms of family members, things of that nature, but I can't really think of a population-based strategy when it comes to such vaccines. Potentially patients who test positive for those HLA, DQ2, and DQ8, things like that. Because there are certain members of the population who may test positive for those genotypes, but not necessarily have the phenotype of celiac disease.
As a gastroenterologist, you probably see so many different issues. How often do you treat celiac? Is it very common?
It would probably depend on who you're asking, because in my practice, I do check for celiac disease a lot. Like I said, it could be a very innocent presentation and I would have a very low threshold for checking it. But I think because of that, I tend to diagnose celiac disease more often. It's because I do check for it more. But yes, I do have quite a sizable complement of patients with celiac disease, but fortunately, at least in my practice, I haven't seen the refractory ones as of yet, because celiac disease, as mentioned, as long as they're very, very vigilant about the gluten-free diet, they tend to do very well afterwards. If anything, the only patients who tend to relapse, by far the most common reason they do, is contamination. So what I mean by that is, at home, they prepare their foods very well. And the moment they eat out, that's when they run into problems. Because even if they order from the gluten-free menu, there's no telling how it's actually prepared in the back room. What if the chef is using a knife that was used to cut bread, for example? Traces of gluten can make its way into the quote-unquote gluten-free.
Would it be, it's that sensitive? I mean, I know there are nut allergies that would create such a problem, but even with celiac, it's the same level of sensitivity?
Not concern? Everyone presents that way, but yes, I do have patients who are that sensitive, definitely. Like I said, whenever they flare, they can trace it back to the time that they ate out. And so they can be very sensitive when it comes to gluten.
Is there anything that might surprise people that you have come across through the years, that like M&Ms or something? I mean, it's like trying to track down kosher food. Sometimes I'm surprised by what is kosher and what isn't.
Right. So one of the less commonly thought of sources of gluten would be the communion hosts, which do invariably contain wheat or gluten. Surprisingly, in our church, we do have gluten-free hosts available for patients with celiac disease, and that's been helpful. And that, again, goes to show how celiac disease and the gluten-free way of life has really entered the psyche of the community. Right. And it's been more accepted and adapted to over time.
Well, 3 million Americans are living with a diagnosis. And as we pointed out, it's underdiagnosed. So probably a lot of people have this.
Right.
So with celiac disease being so difficult to diagnose and also limited with treatment, why is it so important for continuity?
First of all, just going back to what can occur if it's untreated in terms of the deficiencies, it's important to keep up with that. But also in my practice over time, I actually have them come back, maybe a year or two after the diagnosis to do another scope to make sure that the small bowel biopsies are showing histologic response to the interventions. So I think doing that over time is very critical, and you can alternate that with checking antibodies, because for someone with actual celiac disease, if they're very successful at avoiding gluten, their numbers in terms of their antibodies actually go back to normal. That goes back to that acronym I gave earlier about celiac, CELIAC. Support in terms of websites that they can go on to. Celiac.org is a good resource to look into for support. But overall, I think it's one thing to bear in mind for celiac disease. It's a multidisciplinary approach that involves the GI doctor, the nutritionist, and primary care doctor as well, in terms of managing their symptoms and keeping them in remission for as long as possible.
Can it ever go away?
Yes.
Does it ever just disappear?
Technically, I think the answer to that would be a little bit more nuanced. The predisposition to celiac disease, if you're diagnosed with it, that part doesn't go away. Meaning, if you are exposed to gluten, there's a high probability that you would respond to it in the same way in terms of the inflammatory response and the malabsorption that can occur over time. But if, again, the gluten-free diet is instituted properly and adhered to vigilantly, the symptoms, and even on a microscopic level, that can improve over time. So yes, there is a way to make it, quote unquote, go away, and right now, the only way to do that is to adhere to that diet.
So in this region of the country, in Baltimore, for example, where steamed crabs are such a popular food item, many people don't want to eat them without a beer.
Oh.
Can a celiac patient ever hope to enjoy a beer with steamed crabs again?
Maybe the gluten-free beers, yeah.
Is there?
Yeah, they do. They do sell gluten-free beers now.
Interesting.
So, but only that. But the regular beers, probably not.
Right. Well, I mean, what is the general reaction to a patient who gets that diagnosis? What do you say? What's your advice for feeling hopeful?
Right. Yeah. So I think with all our patients, as I mentioned, I think the recognition that this is a potentially lifelong event, because being vigilant about their diets, things of that nature, it's important. But we're here as a team to help you navigate this through the rest of your life.
Thank you, Dr. Parungao, for all that you do to help patients manage celiac disease, and for sharing your expertise with us today on DocTalk. If you live in Maryland in the Baltimore, Annapolis, or Bel Air areas and would like to schedule an appointment with a gastroenterologist, call 443-782-7640. If you have feedback about this podcast, or you would like to suggest another topic for DocTalk, send me an email, deborah.schindler@medstar.net.